عليكم. كل سنة وحضرتك طيبين. Our patient, a 64-year-old male patient, born and lives in Cairo, married with 2 offspring. The youngest is 20 years old, retired, smoker of 1 pack of cigarettes per day for 20 years, no other special habits of medical importance. Past history, patient is hypertensive, since 20 years on control 5 mg once daily, not diabetic. Complaint, right-sided weakness of few hours duration. History of present illness, condition started 6 hours before admission when the patient complained of sudden right-sided weakness and dysarthria with no incontinence, no fits, no history of trauma or fall. Patient came to our ER and MRI brain was done, showing left middle cerebral artery occlusion and brain edema with positive mass effect. Then the patient developed deterioration in the conscious level and was transferred to the ICU. Neurological consultation recommended to keep the patient on mannitol 100 cc every 8 hours, dexamethasone ampoule 8 mg every 8 hours, and Lasix 20 mg per 8 hours as brain dehydrating measures to be tapered over the next week. Kidney function test was done 2 days after starting mannitol and showed a rise in serum creatinine and serum sodium. So mannitol was stopped. However, on follow-up, a gradual rise in serum creatinine and serum sodium was found, so nephrological consultation was done. On examination by the nephrologist, patient was seen intubated, ventilated, Glasgow Coma Scale 6/15. Blood pressure was 160/100 mm mercury, pulse 84 beat per minute, temperature 37, body weight approximately 75 kilograms, no lower limb edema, and the central venous pressure was 1 centimeter water. Urine output was 50 to 100 cc per hour. Chest examination, no abnormality detected, and cardiac and abdominal examination were all normal. Investigations, before starting mannitol, serum creatinine was 0.9 mg per deciliter and sodium was 134 mg per deciliter. After 2 days of starting mannitol, serum creatinine rose to 2.1 and serum sodium rose to 153. After 2 days, at that time on 5/5/2023, mannitol was stopped. Then after 2 days, serum creatinine rose gradually, 3.6, then 4.6 mg per deciliter, and serum sodium rose to 178 mg per deciliter. So how to approach to this case, a patient with AKI and hypernatremia, and how to manage hypernatremia. Definition of hypernatremia, it means increase in serum sodium more than 145 milliequivalent per liter. As we know, a normal serum sodium level from 135 to 145 milliequivalent per liter. First, to approach for hypernatremia, we must assess the volume status of the patient by physical examination. We have 3 status. Patient may be hypovolemic or avolemic or hypervolemic. Hypovolemic hypernatremia means loss of water and sodium, but the loss of loss of water is more than loss of serum sodium. In avolemic hypernatremia, there is loss of water without loss of serum sodium. In hypervolemic hypernatremia, there is gain of water and sodium, and the gain of sodium is more than the gain of water. The second step, we must check for urinary sodium. In case of hypovolemic hypernatremia, if urinary sodium is more than 20 milliequivalent per liter, it means it is a renal loss of water. It is due to diuretics or glucosuria or renal failure. It is if urinary sodium is less than 10 milliequivalent per liter, it means extrarenal losses, such as GIT losses, whether vomiting or diarrhea, or excessive sweating or respiratory loss. In case of avolemic hypernatremia, if urinary sodium is more than 20 milliequivalent per liter, it means we have renal loss through diabetes insipidus, whether it is central diabetes insipidus or nephrogenic diabetes insipidus. If urinary sodium less than 10 milliequivalent per liter, it means extrarenal losses, whether insensible losses through skin or respiration. In case of hypervolemic hypernatremia, if your urine sodium will be more than 20 milliequivalent per liter, it may be iatrogenic cause through using of hypertonic sodium bicarbonate or sodium chloride tablets or hypertonic solutions, or excessive mineralocorticoid release as primary hyperaldosteronism or Cushing's disease, or hypertonic dialysis, whether done by hemodialysis or peritoneal dialysis. So how to treat hypernatremia according to the volume status of the patient. First, in case of hypovolemic hypernatremia, we must correct the hypovolemia first by administration of isotonic saline 0.9% until hypovolemia improves. Then continue using a hypotonic saline 0.45% or dextrose 5%. Then we must treat the cause of losses as relief of obstruction, removal of the osmotic diuretics, or giving insulin in case of hyperglycemia. In eovolemic hypernatremia, we must correct the water deficit by using 0.45% saline or dextrose 5% or oral water to replace the deficit and the ingoing losses. In case of central diabetes insipidus with severe losses, we can use aqueous vasopressin 5 units subcutaneous every 6 hours. And in nephrogenic diabetes insipidus, we must remove the offending drug and use low salt diet, and thiazide diuretics may be used. In case of hypervolemic hypernatremia, we must remove excess sodium by discontinuing the offending agents. We can give furosemide and hemodialysis as needed for renal failure. Back to our patient, the hospital course of the patient. Nephrologist recommends stopping mannitol and Lasix and good hydration of the patient guided by urine output and central venous pressure to be kept from 8 to 10 centimeter water with hydration by dextrose 5% and tap water through nasogastric tube. To calculate the change in the serum sodium, this equation was used. Sodium of the infusate minus the serum sodium over total body water plus 1. We know the dextrose 5% contain 0 sodium, 0 minus 178 serum sodium of the patient divided by 46. That's to say, each liter of dextrose 5% will decrease serum sodium by around 4 milliequivalent per liter. Serum sodium should be measured every 12 to 24 hours, and the change in the serum sodium shouldn't exceed 10 to 12 milliequivalent per liter per day. By using the above equation, patient was kept on dextrose 5% by rate 80 milli per hour and tap water 200 cc every 2 hours through the nasogastric tube. NB, one of the important investigations to be done in hypernatremia is measuring urinary sodium, urine and plasma osmolarity, but it is not done in this case. On following up the patient, there was marked improvement of the serum creatinine and decrease in serum sodium, but the conscious level of the patient still not improved, which may be related to mostly to the cerebrovascular stroke. This table shows the gradual decline in the serum creatinine and the serum sodium through 4 days. And thank you.